Hi students, today we will learn about EMG, that is electromyography. First, coming to the definition of the EMG, it is the study of the muscle function through the examination of electrical signals. That is when a motor nerve is stimulated, that is the alpha motor neuron, it will send signals to the skeletal muscle fibers through NMJ junction, and skeletal muscle fibers will be contracting and it will generate electrical signals. Okay, so this electrical activity we are recording in the EMG. That is, EMG refers to the technique of recording total electrical activity of the motor nerve and the muscle under study. So you see, electro means electric, myo means muscle, graphy means to measure. Okay. So this EMG is useful for the in vivo examination of the muscle activity. So in vivo we can examine the muscle activity and it also quantifies the muscle activity. So clinically we can diagnose some diseases, and kinesiological also means when the hand is moving or when the muscle is when the this part is moving also we can record the EMG. And the machine used to record this EMG is called electromyograph, and the record which is obtained, this one is called electromyogram. So these are the electrodes placed. So okay, and this is the this is also electrodes. So we can test muscle or a nerve. So we first, this is the recording from the muscle. This is recording from the nerve. The history of EMG. John Swammerdam, between 1637 to 1680, he is a he was a Dutch anatomist and biologist. Okay, so he started to work on this. That is, he discovered that stroking the innervating nerve of the frog's gastrocnemius muscle, that is generated a contraction. So he stimulated a nerve which is supplying gastrocnemius muscle of the frog, and he saw a contraction in the muscle. Also, strong evidence that he conducted the first electrical stimulation experiments. Okay, so he also stimulated the nerve and he saw a contraction in the muscle. So it is 134 years before the Galvanic period. That is, Logi Galvan is also a scientist. He also worked on it. See, Luigi Galvani, he he is credited as the father of neurophysiology for his similar work with frogs. So he also worked on the frog's legs and showed that electrical stimulation of a muscular tissue produces contraction and force. Okay, because of this limited instrumentation, his work was not fully accepted until almost 40 years later. He is Carlo Matteucci. He done first practical galvanometer. Okay, he developed a first practical galvanometer in early 1800s. What is galvanometer? It is an instrument used to detect, measure and determine the direction of small electrical currents by means of which mechanical effects produced by a current carrying coil in a magnetic field. So he developed a first practical galvanometer. So electric currents in a coil will produce magnetic field in a galvanometer. In 1838, Matteucci used one to show that bioelectricity is connected with the muscular contraction. And he also demonstrated the existence of action potential accompanying a frog's muscle. Dutchine. In 1850, he applied electrical stimulation to intact skeletal muscles. Okay, and systematically mapped out functions of nearly every facial muscles. And other notable people are William Einthoven. He made a string galvanometer and won the Nobel Prize for it in 1903. It uses a thin conductor wire placed between two magnets. Okay, and all these are also some notables. Now, underlying principle is it involves detecting, amplifying, and displaying the electrical changes that occur during muscle contraction. The electrical events are amplified electronically and visualized on a TV-like monitor or even transformed into sound also. So this is the principle underlying the EMG. So it will detect, it will amplify and displays. Okay, displays on a TV-like monitor or that may be converted into a sound form also. You see this electrode is placed in the muscle and raw signals are generated and they are decomposed also and they can elicit different motor unit action potentials. And the electrodes. So what we need is while recording EMG, okay, we need electrodes. Okay, so the basic recording unit of EMG is a cathode ray oscilloscope, that is CRO. Okay, this EMG can be recorded using two types of electrodes. So they are surface electrodes or needle electrodes. So these are the types of electrodes. Surface electrodes where they are placed on the skin surface. Needle electrodes are inserted deep into the tissue. Surface electrodes may be different types: metal electrodes, self-adhesive electrodes, pre-gelled electrodes, and constant needle electrodes are concentric coaxial needle electrodes, monopolar needle electrodes, single fiber needle electrodes. So surface electrodes are placed on the skin, you know. So it is placed exactly above the surface of the muscle, which is under the study. They are convenient, but they are not precise. So they are not commonly used. Whereas needle electrodes, they are inserted into the muscle, okay, which is under study. And the commonest needle electrode is bipolar concentric, okay, bipolar concentric needle electrode. Okay, this is bipolar concentric needle electrode. It's the commonest needle electrode used. Okay, so it consists of insulated stainless steel hypodermic needle. So we have a needle, hypodermic needle, which is made up of stainless steel and insulated also. Okay, and which contains an insulated fine wire in its barrel. The wire and the needle have bared tips, so the tips are not insulated. With the needle electrodes, it is possible to pick up the activity of a single muscle fiber also. That is advantage of needle electrode. So we can obtain the activity of a single muscle fiber also. See, the surface electrodes applied on the surface of the skin and measure signals from large muscles that lie close to the skin. So they are often silver or silver chloride coated with a suitable conducting gel and can be taped on the skin. So they are made up of silver or silver chloride and gel is applied on the skin and they are attached. Fine wire indwelling electrodes. They are having two strands of 100 micrometer wires inserted into the muscle belly, used for monitoring activity from the deep muscles or from small muscles or narrow muscles. May not be useful for large muscles. And another needle electrodes, they are used to record motor unit potentials from different parts of the muscle and they are inserted into the muscle. Okay, the paired tip of the needle serves as the recording electrode. And the recording or detection electrode. They are either surface electrode or needle electrode or fine wire electrode. So they are the recording and detection electrode. And we need a ground electrode also. Why we need a ground electrode? It provides a mechanism for cancelling out the interference effect from the external noise. So there will be some noise, external noise. So that will be cut by ground electrode. It is attached on the surface. It is a surface electrode and it is attached near the recording electrode. So we need recording and detection electrode and a ground electrode. What are the uses of electromyography? What is kinesiology? Means movement of the person. So in kinesiology it is very helpful. That is the degree and sequence of contraction of various muscles which are participated in a movement we can detect by EMG. So for example, a movement is occurring. Which muscle is contracted to how much degree, and the sequence of muscles contraction also elicited by EMG. And mechanism employed by the body for grading the force of muscular contraction also it is known by EMG. So how much force is generated from each muscle can be known by EMG, and it is also helpful for clinical diagnosis and follow up of diseases like myopathies, and after the nerve injury, muscle injury, how the muscle is responding, how the nerve is responding, is it recovering or not. So we can follow up and we can diagnose the myopathy and neuropathies. So simply to say, to study neuromuscular functions, to know the neuromuscular condition, and to study reflex responses, and to know about the extent of nerve lesions, and it helps to diagnose the muscular diseases. So neuromuscular diseases, reflex responses, okay, these can be studied by EMG. What are the features of motor unit action potential or motor unit potential? The duration is 5 to 15 milliseconds. That is measured from the initial takeoff to the point of return to the baseline. So that is the duration. Normally is 5 to 15 milliseconds. We have three phases. Triphasic. That is, it has a positive wave, negative wave and a positive wave. So this is the portion of the motor unit potential between the departure and the return to the baseline. And sometimes polyphasic also. That is, if it is having polyphasic, that is called that is having more than 4 phases. It occurs in only 5 to 15% of muscles. Coming to the amplitude, it will be from 0.5 millivolts to 2 millivolts. That is measured from maximum peak of negative phase to the maximum peak of positive phase. That is the amplitude. Now coming to the rise time, means duration from the initial positive to subsequent negative peak. What is the time? That is normally it is below 500 microseconds. These are the features of a motor unit potential. Some factors will affect the motor unit potential. What are those factors? Some technical factors or some physiological factors will affect the motor unit potential. Technical factors like type of needle electrode used and characteristics of the recording surface, electrical characteristics of the cable, and pre-amplifier and amplifier, and method of recording. All these are the technical factors which affect the motor unit potential. And some physiological factors like age of the patient, muscle which is examined, and the temperature will also affect the motor unit potential. Now coming to the myoelectric signal. That is the signal which is generated from the muscle. It is converted into an electric signal. The variables that may affect the motor unit potential are proximity of electrodes to the fibers that are firing, and number and size of fibers present in the motor unit, and distance between the fibers, size of the electrodes, distance between the electrodes, all these will also affect. This myoelectric signal is controlled by careful electrode placement, spacing of the electrodes, and choice and size and type of electrode. This myoelectric signal nothing but because of motor unit action potential. And there may be a crosstalk between the in the muscle fibers, between the muscle fibers. Why it is occurring? Because of the electrical overflow or from electrical activity from nearby contracting muscles, okay, that reaches the electrodes. So it should be controlled by careful placement of the electrodes and the spacing between the electrodes and choice of the size and the type of electrodes. So each type of muscle will require some type of electrodes specifically to avoid crosstalk. Now coming to the amplifier. So what is amplifier? It amplifies the signal which is generated from the muscle. So the electrical potential recorded by the electrodes is composed of EMG signal from muscle contraction, and it is also having some unwanted noise. EMGs use differential amplifiers. Ground electrode and active electrode supply input to the amplifier. Difference between the signals will be amplified and recorded. So this differential amplifier, what it will do, it will take the difference between the signal signals which are coming from the ground electrode and from the active electrode. If two electrodes receive equal signals, no activity is recorded. Okay. Now we see this common mode rejection ratio. It will measure how much the desired signal is amplified relative to the unwanted signal. So we should amplify the desired signal only, not the unwanted signal. So if the ratio is higher, then what is the advantage? The better will be the recording. A good differential amplifier should have CMRR, that is common mode rejection ratio, exceeding 1 lakh is to 1. So there will be a better uh, amplification of the desired signal. Signal to noise ratio reflects the ability of the amplifier to limit noise relative to the amplified signal. Okay, so it is a ratio of the wanted to unwanted signal. Where is this noise generated? This noise is generated from internal electrical components. Okay, so that is the signal to noise ratio. Now coming to the gain. Gain refers to the amplifier's ability to amplify signals. Okay, that is the ratio of the output signal to input signal. Okay, so that is the importance of differential amplifiers. Okay, and these ratios. And here we can see insertional activity. Okay, because of insertion we can get some activity, insertional activity. It is caused by needle breaking through the muscle fiber membranes, and it is also seen during needle repositioning. Okay, and normally stops when the needle stops moving. So that is the insertional activity. So we can observe that insertional activity is normal or whether it is reduced or prolonged. Now coming to interference pattern. What is this? The characteristics of the firing. So this is the characteristic. How the firing is. That is the interference actually. The characteristics of firing and recruitment of the motor units during voluntary contraction. They are identified as an interference pattern that is used clinically for the diagnosis of neuropathy and myopathy. So this interference pattern is very much important. Okay, because uh, interference pattern means the waveform which is coming due to recruitment of motor units. That is actually studied in a neuropathy and myopathy. So they are actually diagnostic. So it is normally seen with strong muscular contraction. Okay, the individual action potentials. Okay, coming from the motor units, they are summated with the increasing number of motor units. If you do higher, that is a higher work. See, this is the interference pattern of the normal tracing. This is the neuropathic trace. This is the myopathic trace. So what you can see, this is the normal tracing fully, and then neuropathic trace, it is the distance is more. So between one to one wave, the distance is more. And in myopathic phase, it is almost same as normal, but the height is decreased. That is how the interference pattern will differ in some diseases. See the pattern of EMG at rest, muscle is relaxed and needle is not moving, there is no activity. Insertional activity, when the needle is moved, Okay, to various sampling spots, you can record an activity. So you can record brief action potentials. And coming to motor unit potentials. Now the needle is not moved while the patient makes slight contraction. So needle is stationary, but the patient is making some contraction. A few motor units will be recruited and you can see few motor unit action potentials. There may be biphasic or triphasic for short duration. Now recruitment means what? Subject is asked to make progressively stronger muscular contraction until he reaches the maximum force. Okay, so what you can observe, there will be increase in the recruitment of the motor units and increase in the number of action potentials. Now coming to the analysis of EMG. Okay, so how EMG is analyzed, that is by qualitative analysis and quantitative analysis. First coming to the qualitative analysis. So what is my qualitative analysis? We will see the recording just. Okay, so this is the visual recognition only. Okay, but it provides limited information. Okay, and it will detect some alterations in a few components of motor unit action potentials. But the effectiveness of this method will depend on the experience of the performer, because the accuracy in measurements is limited by the presence of background noise and depends on collaboration from the patients. So this is not commonly used because it depends on the experience of the performer and only few alterations can be detected. To perform qualitative MUAP analysis, the number of phases of a single MUAP and recruitment during voluntary activity are visually analyzed from the graph. So, first a single MUAP is recruited and progressively more MUAPs are recruited. Now coming to quantitative analysis, this is done in two methods, parametric and non-parametric. The parametric method establishes a comparison between sample mean values and reference values. That is, we are taking SD, that is standard deviation. So sample mean values and reference intervals we are taking. That means we are taking the SD, standard deviation. While the non-parametric method considers both extremes of the samples, that is outliers. Both methods offer different sensitivities. So we can do this method or this method. Both will differ. So both will offer different sensitivities. The combination of these two may be the good thing to go. Okay. So you can detect many abnormalities in that sample if we take both methods in quantitative analysis. The principal measurements during a voluntary contraction include, so what all we are seeing in EMG? What are the principal measurements we are taking? So we are seeing count of turns. Count of turns consists of the number of turns recorded in 1 second. So in 1 second, how many turns are coming? It generally reflects the number of active motor unit action potentials, their complexity and frequency of discharge. A turn was traditionally defined as any amplitude change signal of 100 microvolts. So there should be change in the amplitude of 100 microvolts. Okay, so that is a one turn. Next, coming to the mean amplitude between turns and the number of turns divided by mean amplitude between the turns. Okay, so A by T and T square by A. So what is A by T? Mean amplitude divided by number of turns and square of the number of turns divided by mean amplitude. These two also we should calculate. These are the indicators for identifying neuropathies and myopathies, and also they can establish the severity of the disease. Next, coming to the upper centile amplitude. So what is this upper centile amplitude? It defines the upper limit of the peak to peak amplitude. Okay, so one peak is there, another peak is there. What is the difference between the upper limit of the peak to peak amplitude? The spikes with amplitude that exceeds by 1% are identified. Okay, this parameter is normal or decreased in some myopathies, where it is normal or increased in a neuropathy. So, if the upper central amplitude is decreased, it is definitely myopathy, and this upper central amplitude is increased in neuropathy. Now coming to the next thing, activity parameter. It measures the fullness of the interference pattern and is the sum of the duration of specific segments. Okay. So the activity parameter measures the fullness, how full is the interference pattern. Okay. Next coming to the NSS, that is number of small segments. Okay. Number of small segments quantifies the small inflections of the motor unit action potentials, including the smallest segment between subsequent turns. Okay. So subsequent turns it is showing. So what is the smallest segment between the turns? That is the number of small segments. This NSS increases with the number of MUAP discharges, obviously, but reaches a constant value at higher MUAP discharge rates. Means if all motor units are recruited, then what will happen? This NSS will be constant. This parameter has been shown as increased in myopathic and normal or decreased in neuropathic conditions. So we can know that this NSS is increased in myopathy and decreased in neuropathic conditions. Now coming to the spectral analysis. What is this spectral analysis? It is traditionally consists of fast Fourier transformation of the EMG signals. It is the output displays the range and amplitude of the component frequencies. Spectral analysis is used extensively in the study of muscle fatigue. So the spectral analysis is especially used in the study of the fatigue of the muscle. Next coming to the automatic decomposition electromyography. It comprises the extraction of MUAPs from EMG interference pattern, which is employing digital filtering, and the decomposition and analysis of validated MUAPs. Measured parameters are duration, amplitude, rise time, area, ratio, area by amplitude, and number of phases, turns, and fire rates. All these will be studied in automatic decomposition electromyography. Okay. So in the first figure also you are seeing that the entire EMG is decomposed into individual MUAPs. So individual MUAPs will be studied in all these parameters. Okay, so it is done by digital filtering. Now coming to the last one, computer aided motor unit nerve stimulation. High density multi-channel EMG recording provides the spatiotemporal information for motor unit action potentials. This technique allows the assessment of the number of functioning motor units. So, for example, if you want to know in that muscle how many functioning motor units are there, okay, you can go for computer aided motor unit nerve stimulation. Okay, so it will give spatio-temporal information. So, in which space, how many motor units are functioning and how fast they are recruiting. So, from all these things, you can study the EMG and you can know the any pathology that is neuropathy or myopathy. See this? You can stimulate here or you can stimulate here. This is the latency and this is the positive peak. This is the negative peak. This is the total duration. Actually, this is not amplitude. From here to here, there is a height, that is the amplitude. This is the M wave which you are seeing normally, that we have seen in the previous slide. Okay. So, in abnormal conditions, okay, you can see some little responses. That is abnormal, not abnormal, but some supramaximal stimulation, submaximal stimulation. If you stimulate supramaximally, okay, of some nerve, that is median nerve at the wrist joint, you can see the recording in the abductor pollicis brevis muscle, that is showing F wave. And if you stimulate with the submaximal stimulation of the tibial nerve in the popliteal fossa, you can see some H wave. Okay, so these are the late responses. So after getting M waves, we are getting these late responses because of the supramaximal stimulation and submaximal stimulation of the nerve. Now coming to the abnormal patterns of the EMG. So what are these abnormal patterns? There may be fibrillation potentials. That is, these are the fibrillation potentials. These represent spontaneous repetitive depolarizations of a single muscle fiber. So there will be spontaneous and repetitive depolarizations occurring in the single muscle fiber. They are not visible with the naked eye. Why they are coming? They may result from denervation of the muscle. Okay, nerve supply is cut, and due to metabolic dysfunctions, or maybe due to inflammatory diseases like polio, or maybe due to trauma, or maybe due to lower motor neuron lesions. So all these things will exhibit fibrillation potentials. So here he is showing fibrillation potentials in a partially denervated muscle. Now, positive sharp waves. So these are the positive sharp waves. Okay. So these represents asynchronous discharge of a number of denervated muscle fibers. So these it is also seen in the denervated muscle fibers. Sometimes you will get asynchronous discharge. Okay, from many denervated muscle fibers. This reflects an altered membrane excitability. Why it is because of altered membrane excitability, usually accompanied by fibrillation potentials. Next, coming to the fasciculation potential. It represents spontaneous discharges from a group of muscle, okay, muscle fibers. So, fibrillations are because of single muscle fibers. Fasciculation because of group of muscle fibers. They will discharge at the same time. So, these are called fasciculations. These are visible with our naked eye. They will seen as the small twitches in the muscle. It is seen with the irritation or a degeneration of the anterior horn cell, and it may be because of chronic pain or a nerve root compression, cramps or spasms. Okay, so this is called fasciculation potential. So you see this, and sometimes it may be seen in normal individuals also. But pathological significance should be given if it is seen with the fibrillation and positive sharp waves. So if fasciculations are seen with fibrillation or fasciculation are seen with the positive sharp waves, then it is a pathological condition. Otherwise, in some normal individuals also we can see some fasciculation potentials. So what are the differences between fibrillation potential and fasciculation potential? So fibrillation is because of contraction of individual muscle fiber, and it cannot be seen through the skin. When muscle fibers lose contact with their innervating axon, that is denervated muscle fibers will show fibrillations. It may be because of neuropathy or myopathy. And see the amplitude, 10 to 100 microvolts in amplitude, very small in amplitude, and they are of 1 to 2 milliseconds in duration, very small duration, and 100 hertz in frequency. So all things are low, that is 10 to 100 microvolts in amplitude, 1 to 2 milliseconds in duration, and 10 hertz in frequency. Now coming to fasciculation, it is because of contraction of individual motor units. So individual motor units are contracting, and these contractions are visible through the skin, and it occurs as a result of additional nerve impulses generated, and it is because of mostly due to neuropathy. And see the amplitude, it is 50 to 500 microvolts in amplitude, and 2 to 4 milliseconds in duration, and 2 to 20 hertz in frequency. So it is more than fibrillation. So this amplitude is more, we can see through the skin. So these are the differences between fibrillation and fasciculation. Now coming to myotonic discharge or complex repetitive discharge. So this is the figure of myotonic discharge. So it is seen with the lesions of the anterior horn cell and peripheral nerves and myopathies also. Okay. It is probably triggered by movement of needle electrode within unstable muscle fibers. So this is the myotonic discharge. Okay. It is seen mostly in these pathologies. You see this? This is normal M wave. Okay. So what are the phases? You will have 1, 2, 3 phases. This is total amplitude. This is total duration. Okay. So what you can see, morphology and parameters of the motor unit action potential during normal EMG recording. This A figure is a normal MUAP with 3 phases. Okay. Polyphasic means more than 3 phases. So that is having 4 or 5 phases. So these are the 3 phases. So you can see neuropathic MUAP. How it is? The it is showing high amplitude. Okay. And enlarged MUAP recorded in chronic neuropathy and reinnervation. So it is a recording obtained from chronic neuropathy. So the amplitude is very high. Now see this myopathy and some neuromuscular junctional disorders. Okay, it is showing small amplitude and it is also having polyphasic. Okay, so polyphasic and more amplitude seen in neuropathy, polyphasic and low amplitude this MUAP seen in myopathy. See the interference pattern, it is full. So this is about normal recording. Now coming to the neurogenic lesion, it may be due to lower motor neuron lesion or upper motor neuron lesion. So the insertional activity is increased in lower motor neuron lesion when it is normal in upper motor neuron lesion. And spontaneous activity, okay, is present as fibrillatory waves or positive waves in the lower motor neuron lesion. There is no spontaneous activity in upper motor neuron lesion. And motor unit potential is large unit, okay, and there is a limited recruitment in a lower motor neuron lesion, normal in upper motor neuron lesion. So the lower motor neuron lesion is showing a large potential, that is large amplitude. Then interference pattern is reduced. Okay, interference pattern is reduced. There is a fast firing rate. Now coming to the upper motor neuron lesion, there is insertional activity is normal. There is no spontaneous activity. Motor unit potential is normal, and there is reduced interference here also, and there is a slow firing rate. When you compare these two, there is reduced interference pattern. But when we compare these two, upper motor neuron lesion is having slow firing rate than lower motor neuron lesion. Now coming to myopathic lesions. It may be due to myopathy or polymyositis. In myopathy, the insertional activity is normal. There is no spontaneous activity and there is early recruitment and small unit. So in myopathy, there will be small amplitude in the motor unit action potential, but the interference pattern is full, but it is of low amplitude. Now coming to polymyositis, the insertional activity is increased and there will be fibrillations and positive waves. But here small unit, that is early recruitment will be present and the height is decreased of the motor unit action potentials. And here also interference pattern is full but of a low amplitude. So when we study the interference pattern and the duration and the amplitude, all these things, we will come to a diagnosis of whether the muscle is normal or whether it is having lower motor neuron or upper motor neuron neurogenic lesion or myogenic lesions like myopathy and polymyositis. So we can decide the disease. Okay. So up to now what we have discussed, we have discussed electromyography. Okay, and in a neurogenic lesion and myogenic lesion how the pattern will be. So we have seen the definition and we have seen the principle and we have seen the recording technique. That is, recording technique is including surface electrodes, needle electrodes. Also they are recording electrodes and ground electrodes. Okay, and amplifier and one more thing, transducer will be present. So transducer will be doing transformation of one form of energy into other form of energy. Now this motor unit action potentials will be converted into electrical signals by transducer and they are amplified through differential amplifier, and you have to know the signal to noise ratio and the other ratio and gain. So and how normal EMG looks like and how it will be studied under all these parameters. Okay, some 6 to 8 parameters are there. And next what is the normal insertional activity, spontaneous activity, and motor potential and interference pattern, and all these things you have to study, and you have to practice these diagrams. And what are the fibrillation potentials, fasciculation potentials also we have learned. The next video is about disorders of the skeletal muscles. So in these disorders, what we will mainly study about muscular dystrophy, that includes Duchenne muscular dystrophy, Beckett muscular dystrophy, and malignant hyperthermia, hmm, myotonia, myasthenia gravis. This myasthenia gravis is important in neuromuscular junction, and abnormal muscle tone, metabolic myopathies, fibrillation, and a denervation hypersensitivity. Okay, so all this we will learn in the next video. So denervation hypersensitivity itself consists of a separate video, and remaining all we will study.